welcome you to this diaspora arm of CPAN. The topic tonight before us is evidence-based clinical pharmacy practice, data-driven decision-making. Evidence-based clinical pharmacy practice, data-driven decision-making. This topic will be presented by no other person, but our own very Dr. Tari, the Pioneer Assistant Secretary. I'm just knowing about that now. And also a PhD candidate, graduate assistant, Department of Pharmaceutical Health Outcomes and Policy, University of Houston College of Pharmacy. Dr. Tari Late is a BPharm holder, a PharmD holder, an MPharm holder, and a PhD in view. Welcome our presenter tonight, who will be doing justice to this very topic, and hope we all learn, contribute, and ask necessary questions where we have to. Thank you all. Ladies and gentlemen, I'd like to welcome Dr. Tari Late for her presentation tonight. Dr. Tari, over to you, please. Are you, sorry, before that, I omitted something. Dr. Tari, can we have a prayer, please? An opening prayer before she presents to us. I'd like to invite our dear own Dr. Teresa Pounds. Please, can you, Dr. Pounds, I can see you online. Please, can you say the opening prayer for us as we proceed? Hello, is Dr. Pounds there? Dr. Bello, are you? I hope everyone is hearing me. Hello, I hope everyone is hearing me.
Yes, I can
Dr.
hear
Pounds,
you.
Dr. Bello. Okay. Please, if Dr. Pounds is there, can she say the opening prayer in the absence of Dr. Pounds? Pharmacist Hawa, our Benway, can you unmute yourself and say the opening prayer for us, please? In the absence of Dr. Teresa Pounds. Hello? Will, are you there? Please, all right? Sister Hawa, are you there? It's like the two persons I'm calling forth are not available. Dr. Bello, are you with me? Okay.
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 Let us pray.
Dr. Pounds, okay.
This is Dr. Pounds. I would like to build over to Dr. Bello to say the opening prayer because I'm emotional. That's why I didn't hear you right away. So, Dr. Bello, can you please do justice of this prayer? But thank you for the opportunity.
Thank you, ma.
Okay, ma. So, in the name of Allah, the most gracious, the most merciful, we give thanks to God Almighty for this opportunity again to meet and have another meeting By your grace, we commit everything to your hand for wisdom and for guidance. And we pray in the long run that this knowledge we're about to learn this night will be of benefit to us and to humanity in general. Amen. Over.
Amen.
The prayer is over, Dr. Ahmed. Yeah. Amen.
Thank you, Dr. Bello. You, Dr. Tari, over to you. Please hit the floor running. Thank you, ma'am.
Okay, thank you so much, Dr. Ahmed, for that wonderful introduction. I wanted to confirm if everybody can hear me.
Yeah, we can hear you.
Thank you. I'm really excited to be here today. Good afternoon, good evening, or morning. I don't know the demographic of people, but we are in the afternoon section now in our day. So good afternoon or evening, everybody, and welcome to this section on evidence-based clinical practice using data to inform clinical decision-making. I'm super excited to be here, and I am grateful for the privilege of speaking with this great audience this evening. The introduction has already been done, so I'm just going to dive into the core of today's discussion. Okay, so we know that clinical evidence-based practice is like a core area for us as pharmacists in clinical practice, and you know, it's more or less a cornerstone of healthcare, and it helps us to ensure that the decisions that we make as clinical pharmacists are backed up by relevant evidence, and that's what we're going to be doing today. So by the end of this presentation, you're going to understand the principles of evidence-based practice. We're going to learn how to effectively use data in clinical decision-making, and we're going to explore some really simple case studies, 2 of them, and to see how this case studies apply to the real-world scenario. So what really is evidence-based practice? I would like for us, I love interactive sections. So if you all can just put in the chat what comes to mind whenever you think of evidence-based practice, you know, in a layman's term or whatever comes to mind, can we just put it in the chat before we proceed? I'll just give a few seconds for that activity. What comes to mind when you hear about evidence-based practice? I've not seen any result on the chat box yet. Anything that comes to mind, you can just put it in there. Okay, I see someone says data supporting practice, data collection. Awesome. Can we have more people put in what they think about clinical-based, evidence-based clinical pharmacy practice? What comes to mind? Okay, I'm just gonna move on. Thank you so much for, okay, proven real clinical experiences, practice based on scientific studies. Awesome. Using previous studies and outcome to guide your practice. Beautiful. Thank you so much. Yes, everything in the chats is really what evidence-based practice is all about. It's just simply backing your practice decisions by evidence, and those evidence are generated from, you know, searching through the online search to find the best evidence to suit the particular decision you're trying to make. And that search has to be done systematically. It's not just going on Google to say, for instance, what is the best or what is the recent guideline for the treatment of hypertension. Is using a systematic approach to do this search. I was hoping that I was going to show this in course of the presentation, but maybe I don't know how fast we would go, but I would have loved to do that demonstration on how to generate this evidence. But so it is a systematic approach that ensures that the patient care is based on the best available evidence. And when we use the best available evidence that is not haphazardly generated, but generated systematically, we would have improved outcomes, of course, and that would even help, the pharmacist to have a better public image, like, your profiling solution that is working. Okay, so why is this important? Evidence-based practice. Why is it important? So evidence-based practice, when we base our practice based on evidence, it helps us to improve the care that we provide for our patients as clinical pharmacists, irrespective of the setting that we find ourselves, whether be it in hospital, community, FDA, wherever. Our goal is basically, we all have one goal, irrespective of where we practice, to improve the outcomes of patients, to make sure that we are using the most cost-effective intervention to get the best possible outcome. So overall, we have a common goal, and evidence-based practice helps us to achieve that goal because the care that we provide will be better because it's based on evidence. And of course, when we provide better care, the result would be better outcomes. And like you're applying effective treatment, you don't have to try treatments that would fail and then move on to the next one. That way we are, even wasting resources. So that is why it is important to base our practice as clinical pharmacists on available evidence. So there are basically 5 steps of evidence-based practice. Sorry. So we have the ask. First of all, we ask the question. This involves like formulating the clinical question. There is someone that is not muted that is making a noise. I don't know if that can be taken care of. There's a particular noise. Okay, thank you. So the 5 steps of evidence-based practice: first, you formulate a very clear clinical question. And we're going to see examples going down the slides. And then you acquire the knowledge that you would use in making your decision by searching for the best evidence. And we are going to see how to search for the best evidence. And then you critically appraise this evidence when the search has generated the evidence. We're going to appraise them. The appraisal process is just simply trying to eliminate evidence that might not be so strong and go for the strongest and the most evidence with the most quality and highest strength. We'll understand that in the slides following. And then when we are able to identify the best evidence, then we apply it to the specific clinical scenario. And then, of course, when we apply an evidence, sometimes it can be, when we apply the evidence to whatever intervention we are doing, both pharmacological or non-pharmacological, we expect an outcome, right? So we would eventually assess to evaluate the performance of that intervention that we applied. Like, what is the outcome of this intervention? I used a CCB like amlodipine to provide a hypertensive intervention for a hypertensive patient, how much of the blood pressure has reduced. That's, just an example. And so formulating the clinical question, there's the simple framework called the PICO framework. I mean, this can be used not just for clinical questions, but can also be used for any research for that matter. This is like the simplest framework that exists. I like to use it a lot. The P stands for patients. You're simply asking, who are my patient population? Are they hypertensive patients? Are they HIV patients? Are they people with hypertension and diabetes? Are they, depending on the practice scenario? And then the I stands for intervention. What is the intervention or the treatment? What am I looking at? Am I looking at using a CCB like amlodipine versus amlodipine hydrochlorothiazide and see which has a better outcome? And then the comparison is, what is a control? Okay, we have people on HCT, for instance. Now we want to step up to add nifedipine or amlodipine, as the case may be. How do they compare? That's a comparison. What are you comparing against what? The standard is HCT, for instance, and the comparison is the improved therapy, HCT and amlodipine. That is just what intervention stands for. And then the outcome, for instance, like, okay, HIV patients that also deal with mental health conditions like depression, anxiety, and things like that. If these patients are linked up to a mental health clinic, does it improve their HIV outcomes like CD4 counts, things like that? So the PICO framework is really a very simple framework that you can use to formulate that question. Remember, the broad goal is trying to generate evidence that would, help us in making sound clinical decisions. So acquiring the evidence. We acquire evidence by search, online search. Well, what do we search? We don't just go on Google and search best therapy for hypertension, for instance. We search medical journals, we search databases like PubMed. I hope I'll be able to do a quick PubMed search, maybe at the end of the presentation or something. So these are like the places we try to get the evidence that we're going to use to apply to our clinical decision making. And then we can also use like the clinical guidelines and protocol. We can, while doing those search, there are search strategies that when you apply, you get the best evidence. Because if you just use a plain search, like a sentence or a phrase, what is the best therapy for this? You would have thousands, or let me not say millions, but thousands of results. And the one that is on top does not necessarily mean that that is like the best. So there are ways to do this by using specific keywords, Boolean operators to refine the search in order to get the best outcome from that search. So when we talk about critical appraisal of the evidence, it's just a way of systematically looking at the research that has come out from the search, right? We're looking at the validity. How valid is the study? Is this study done with a population that is nationally representative? For instance, like, okay, if you see a study done in just Ibadan, for instance, and a study that was done in all the 36 states being involved in the population, the one that is done in the, like, nationally is a stronger evidence, because it's more valid. Like, it shows that, okay, this result is consistently the same across states, not just the center. That's like a case study, more or less. You're looking at the relevance. Was it done in 2016? And then you're trying to use that for an evidence in 2024. That doesn't work, because there are things that would have changed in the clinical landscape? And then what is the applicability of this evidence? Am I using what is being done in the US to apply to patients in Nigeria? That wouldn't, be an effective way to do that. So that is what the appraisal process does. So there are tools that you use like checklists. I could, put up the links of all these things maybe after this presentation for people who are interested to further look into them. There's what they call the PASP checklist and the grade system that will help you evaluate the quality of the studies and, just determine if it's reliable for your particular practice setting. So talking a little bit about the CASP checklists, that is just like the Critical Appraisal Skill Program. This tool is particularly designed to help people to systematically assess how reliable or relevant a published paper is. So there are different tools for different types of studies, such as the randomized controlled trials. Depending on the study you're doing, there are different tools to check the relevance or trustworthiness of this study. And each of these types of study have their different tools. There's a website, I can put that also in the resource I'll try to gather, that you can use to ascertain the, relevance of the evidence you're trying to generate. And then the grade system is also like something to help us identify, to critically appraise the evidence. Like it looks at things like bias. Is there a risk of bias in the study? Are these studies consistent? If you repeat the study in another setting, will it give the same results? Is the evidence direct or indirect? Are there things that are not precise? Thinking about, when you have some findings and you see, oh, there is a difference, but the p-value is 0.05, for instance. That's a very tricky one, because if it's less than 0.05, we say it's statistically significant. And if it's greater than, we say it is not statistically significant. So when you have certain results that are not precise, this grade system helps you to make the decision whether or not to use that particular article or information to make your decision. There's also publication biases, depending on the journal, is it published in English, and many other things like that. So let's move forward to the quality of evidence. There are 4 levels of quality of evidence. We have the high, the moderate, the low, and the very low. So for the high evidence, we know that we are trying to ascertain, or rather we have identified the evidence, and we saw from that evidence that it is unlikely to change, meaning you are seeing the same results consistently. For instance, let's say there is high prevalence of antibiotic misuse in Nigeria. And then you have a hospital in maybe University of Uyo Teaching Hospital, University of Port Harcourt Teaching Hospital, Ibadan, Benin, and all of these studies have consistently say, oh, there is this 90% use of empirical therapy, for instance. That shows that, okay, we have confidence that when we say there is high prevalence of antibiotic misuse, it is actually true. So that is like you have identified that evidence is of high quality. So the goal, we have moderate and low and very low. The goal here is to use the highest possible quality of evidence, except you're unable to get that kind of evidence, then you move to moderate. But ultimately, we don't want to look at very low evidence at every point in time. In order to make the best decision, we go for the highest quality of evidence. There are other caveats to this, but as we go forward, we're going to see like, okay, what else should you consider if you identify a high quality evidence? What else should you consider? What else is important? Or do you just go ahead to implement the particular evidence as long as it's high quality? We're going to see that as we proceed further. So, applying the evidence to clinical practice. This is just like you're bringing this evidence into your practice, your own practice setting. Like, you consider the patient's preference, you consider the patient's values. That's what I'm talking about. Like, sometimes you may have identified an evidence. For instance, I remember when I was in geriatric practice, there was this patient, he was beginning to have some bit of renal inconsistencies, and the ideal was to place him on insulin because he was diabetic. But this patient would just refuse insulin. Some people have their reasons. And since the patient refused, we can't force the medication on him. And we continue to use the oral antidiabetic agents that he could accept. But then there was a day I was speaking to a nurse in, I think, the medical outpatient clinic, and she told me about something I found really interesting, that there is a diabetic care group, like a social network kind of thing, that all diabetic patients come, the clinicians are there, and they share their experiences and things like that. So that's really sounded interesting and exciting to me, and I immediately thought of this patient. And the next time I met with the patient and his wife, I was like, oh, I found something that you might be interested in. I told them about it, gave them the information. And, they went further to attend the section. And it was after that section, the patient saw, other patients that are diabetic as well. Like, he saw that using insulin wasn't a big deal, and, people sharing their experiences and things like that. And surprisingly, he accepted the use of insulin, which really helped to improve his outcomes even further. So I'm just trying to tell us that the role of patients' preferences and their values is really critical when it comes to applying evidence. Okay, so we want to make sure that the evidence that we choose is not only effective, but it also aligns with their peculiar circumstance. So that is like individualizing the therapy. What do they need and what are their preferences and values? Assessing outcomes, that's simple, measuring parameters, clinical parameters, his blood glucose, what was it before the intervention, what is it after the intervention. So just key performance index and outcome measures, what's the recovery rates, did the length of stay in the hospital improve after using this intervention? Did hospitalization rates reduce? Was the patient coming every month and was being admitted? And then when you started using a particular therapy, admission rates decreased to maybe once in 3 months or once in 6 months, things like that. That is how to assess the outcome, to be sure that the intervention that you've applied to the patients is really working. So the role of data in clinical decision making. So data plays a very important role. I don't know what the landscape is like right now in Nigeria, but for the most part, from the experience I had, I never really had an experience with secondary data like databases. Maybe some of you here might know some, and I'm interested to know those databases that might be available in Nigeria so that I can also explore them for some relevant questions, to see how to use them to answer relevant questions. But for the most part, for what what I knew, and I mean, my knowledge may be limited, we didn't seem to really have like much data. We have a lot of data, like we generate a lot of data. Every one of us generate data every now and then, but like, you know, having access to the data in such a way that we go to, you know, collect, clean up, analyze, and things like that. I wasn't exposed to that practice. So, but it is very crucial because it helps us to get insights of our patients. For instance, when we say data, it sounds big, but if you take a patient's folder, that is data. The physical folder or the electronic medical record. And then you go back in time to see, oh, this patient was on amlodipine before. Why did they change it to telmisartan, for instance? That's data. It helps you look back in time, you know, to determine what has happened over time, what was the result of the treatments like, what were the outcomes, what has been the trend, has this patient been fluctuating in terms of their outcomes, are they always high and low? If you see things like that, inconsistencies like that, it might be an indication that there is a non-adherence issue here, and it helps us to probe further. So data is really, really critical in making clinical decisions. We cannot overemphasize the importance of data. And when we talk about data, we have the electronic medical record, like I mentioned before, we have the clinical trial results, we have patient registries and things like that. So when we use data very well, we'll be able to make very informed decisions that will help our patients get the best outcome. So data analytics in clinical pharmacy. This is just using statistical methods. Some of us might be familiar with some statistical method and packages like SPSS, you know, or Excel to analyze the data. So there are techniques that can be used like regression, machine learning, you know, big data analysis to uncover what the trends are and all that. But all these sound complicated, but basically what we are just trying to do is to see if we can use past data to predict, you know, future outcomes, right? So when we look back in time, what is the pattern of this group of patients, for instance? Are they constantly improving or they are fluctuating and all that? If we put it into a data analysis, having enough data analysis tool, having enough of the population to make such analysis, we'll be able to, you know, come up with results to say, oh, in this patient population, we have seen that people who use, for instance, I always use the amlodipine example. People who use amlodipine hydrochlorothiazide are more likely to have improved blood pressure by 5%, 10%, as the case may be, as compared to those who use just HCT, something like that. So it's not that complex, you know. I know a lot of us, even me, I was very skeptical when I came to my current program and I saw that it was a lot of statistical analysis. I was thrown away, like, I was like, oh my God, I'm just a clinical pharmacist. I don't know anything. Data, I've never used all this software before and things like that. But, you know, it's not that complex. I know many pharmacists used to say, oh, data analysis is not for me. But it's really important for us to, you know, get these skills as well. Not like a statistician, but at least to be able to, you know, analyze just very tiny little bit of data to help in our clinical decision making. Okay, real world evidence just refers to data that have been collected in everyday practice, not clinical control, clinical trials. So when you have the trials and the drug is approved, for instance, you have that drug going to the drug market and people start using it normally. Now, the real world evidence, which is what my program is very, in fact, that is all we do. We don't do trials. I only was involved in trials this summer. For real world evidence, we go and check what the people in the clinic are using, the data that have been collected, and it's electronically available. Some of them are available online. And then we see that's real world evidence, not controlled trial. So it is very valuable. In fact, the Department of Real World Evidence, they call it different names, is very vital in like pharma companies. They can't function without the real world evidence department. Some of them, they call them health economics and outcomes research, health outcomes and policy, things like that. So it helps us to understand not just what was done in a controlled environment, but in the real world, what is going on, like how are these patients responding and things like that. So first case study, I'm using this HIV mental health because that's what my dissertation, this the population of patients I'm using for my dissertation. So first case study, if we want to look at how we can use generate clinical questions. Okay, the question, for instance, is, does additional mental health treatment improve clinical outcomes for HIV patients that have other co-occurring mental health condition? I've mentioned this before. So if we want to generate the evidence, we would search and review studies from like PubMed or Cochrane Library. And then the appraisal is, basically selecting the high quality randomized controlled trials. We're going to see the hierarchy of evidence and to know what to use pattern, what is the highest or what's the lowest. And then the application is like, okay, we are implementing a mental health treatment program alongside with the normal HIV care that these patients are receiving. And then the outcome would be, okay, for instance, the patients were non-adherent to their medication, to their HIV treatments, but when you treat them in the mental health program and probably they become not depressed anymore, that the depression has been taken care of, for instance, they now have better adherence, which would now lead to better outcomes in their HIV treatment. So that's just the first case study. The second one is, okay, if we're looking at cardiovascular disease management in diabetic patients, the question would be, does intensive lifestyle modification reduce cardiovascular events in diabetic patients? And we search for evidence like, guidelines, meta-analysis. Meta-analysis is just like a systematic review, but it's like a stronger one where they put all the results of the articles together and analyze it to get one result, which is a strong evidence. And then you appraise it by identifying the studies with the strongest evidence that supports that kind of intervention, lifestyle as an intervention. And then integrating it into the patient would be, bringing in lifestyle modification into the care plan of the patient. And then you can look at the outcome. Is there reduced incidence of cardiovascular events? And is the patient's quality of life better? So moving forward, we're going to see, what really prevents people from implementing evidence-based practice. We say this, we preach this, we hear, we read, we attend seminars and things like that. But people like translating this knowledge into practice, like in your everyday practice, when you want to maybe make a recommendation or you want to advise the physicians or something, like, do we remember all these things and say, okay, how do I integrate these things into practice? So one major barrier is limited access to high quality evidence. like I said, most persons, like I said earlier, most persons might just go on Google, or these days where we have AI, they can just use ChatGPT. What is the treatment plan for this? Especially maybe people who are young in the career. Even I did it, like when I was very young in my career, I was managing, or like, do I say heading a community pharmacy in Uyo at that time. And sometimes, oh my God, they just come in with things that I've never heard before. I will start chatting up my friends who are pharmacists with more experience, or doctors. I'll be like, what do you give to this patient for? So those kind of things is not a high quality evidence, because we are just taking one person's opinion. Okay, let me prescribe Coartem, for instance. So lack of access is one big thing that makes people not to implement this. Time constraints. We all know that there is never enough time, even to do the normal counseling. Sometimes when the pressure is so high, practically what I've seen in clinical settings, we just give the patients the drugs, which is not good. But these are, of course, obvious impediments to the implementation of evidence-based practice. And also, I've come to realize that change is one of the biggest things, like, to achieve. There is always resistance towards change, even in our everyday life. Like, oh, I want to start exercising or going on walks. Your system and everything is already used to not doing that. So implementing that takes extra effort. So we need to, apply strategies that would help us overcome these barriers. And some of those strategies include, like, getting more involved, like trainings like this, I'm hoping would, help in some ways to activate a clinical decision-making center, of the brain. Like, anytime we are faced with clinical decision, we think of, oh, we learn this or that, how do we search, and things like that. Sorry, I need to plug my laptop. Sorry about that. So, and then improve access to resources would also help us to overcome these barriers. Now, talking about tools and resources for evidence-based practice, we talked about the PubMed. There are other softwares like EndNotes. These are just like reference managers. I just listed them here. Some of you might be familiar with them already. And then continuous professional development programs. I know we have a lot of them in Nigeria. Workshops, courses. In putting up the resources, I'm going to add some of these things for people who might be interested. So the role of clinical pharmacists in evidence-based practice. Now, when it comes to clinical pharmacists, practically in our settings, how can we play a role? We can conduct medication reviews in order to optimize therapy. I remember in the geriatric center, I used to do that a lot. I remember there was a time I saw one person taking 41 medication, not exaggerating. And I couldn't believe it. I thought it was a requisition because the doctor sat in my office and was writing this prescription. And I was like, what's that you're writing? He said the patient prescription. I'm like, no way, one patient, up to 41 medication. So I became interested in that patient. And I did a thorough medication review to try to optimize that treatment plan, and discovered a lot of, repetitions, using one medication to treating side effect with another medication that will bring. So after doing it, we reduced it to like 20. But eventually, the medical team. Sorry. Okay. Eventually the medical team accepted some of those recommendations and, effected the change and all that. So we really have a very important role to play in terms of, practicing based on evidence in our different clinical settings. And also educating the patients and the healthcare professionals. Some of us may think that, the doctors they are prescribing, they already know, but when it comes to the drugs, the pharmacists have the upper hand and you have more information. So it's always important to collaborate with these professionals in order to have the best kind of practice. Okay, I've talked about collaboration already. So, looking at future trends in evidence-based clinical practice, we know that these days there is increased use of artificial intelligence and machine learning to analyze data. So that's like just something to keep in mind for people who might be exploring, And then personalized medicines approach is something that is really evolving or coming up these days in the clinical practice, and also expanding telepharmacy and remote patient monitoring, where you have some patients wearing some device and you're able to see, for instance, the glucose trend like throughout the day. Was there a steady maintenance of their glucose level, like optimal glucose level, low glucose level? Was there a spike? It's really interesting, these things. I don't know how common it is in Nigeria, but it's quite common here. So you can really monitor to say, oh, why did you have this spike? The patient may be like, oh, I ate so diet or something. So just something to keep in mind. Talking about policies and guidelines, it's very important to adhere to these policies because it will ensure consistency and quality in the practice. For instance, if you want to look at guidelines from the Ministry of Health locally or internationally, like, what does the CDC guidelines say about COVID-19 vaccine or something? Or what does the WHO guidelines say about these things? So it's really, really, really important. And you'll be surprised at how many institutions that don't even have guidelines. I remember a study we did on antibiotic use. We had done a quantitative study by really going into the folders and seeing how are these drugs prescribed. And then when we saw, like, it's really interesting that over 70% of overuse of antibiotic. Why? So we went further to do like a qualitative study where we interviewed the doctors and nurses and even pharmacists, lab scientists that were involved in antibiotic use. And I was really shocked to see that most doctors don't even know about the guideline. Like, oh, is there a guideline? I don't know about such guidelines. Some of them would say, oh, I use the national guideline. But is that national guideline still transferable into your practice? As much as possible, we try to say these guidelines should be adapted, to the particular clinical setting, and also culturally adapted to that's like the culture of the patients or how things are being done in that particular clinical setting. So that is that for policies and guidelines. And basically everything we've said, at the end of the day, we want it to be impactful on our patients. And that shows in terms of the treatment efficacy, the safety. When we use evidence-based guidelines, we get the safest therapies for our patients. There's enhanced safety and efficacy of the treatment. let's reduce healthcare costs really by not trying so many things before finally getting to the right one. And of course, when the patients spend less, they are happier. When they get well, they are happier. So there will be increased satisfaction, quality of life, and like I would always say, improved public image of the pharmacist. I remember once a patient said, when I was doing the geriatric practice, and I was just trying to incorporate this evidence-based practice thing into my practice, and she was like, I've not seen this kind of counseling before. Like, I've not really received this kind of counseling. And since that day, it was so shocking to see that that particular woman, even if she goes to like MOPC clinic, it is miles away from where the geriatric center is. She would come with all her medications. And even if the pharmacist is not around, she will sit down to wait and say, I want you to see, I want you to vet it, I just want to make sure that, I was given the right thing and you helped me to use it properly and things like that. And that was something that really gave me some good level of satisfaction, like, oh, I'm making impact and affecting the lives of these patients positively. So in all, our patients are improving, they are more satisfied, they have better quality of life. It improves our image as pharmacists, clinical pharmacists. So thank God I'm right on time, 2 minutes more. So basically, evidence-based clinical practice is essential for improving patient outcomes and ensuring that the care that we provide is efficient, effective, and patient-centered. And continuous learning and adaptations are key to staying current with the latest evidence and applying it to our peculiar clinical circumstances. With that, these are the references, and thank you. Oh, special thanks. Let me thank Dr. Aneta for co-opting me into this. Yeah, I feel privileged to deliver this lecture, and the CPAN diaspora team and the Global CPAN, thank you so much for having me. I'm indeed grateful for the opportunity, and I would now take questions. Thank you.
Thank you, Dr. Tari. Great delivery over there. In fact, is a wow. The big wow. We want to celebrate you especially for making CPAN proud, CPAN diaspora and CPAN global. I can see the attendance here, almost the attendance is really encouraging. That was a very delivery. Thank you for this presentation, Dr. Tari. We, just like she said, it's time to take questions. Please, if you have questions for our dear Dr. Tari, can you indicate by the raise of hand, and we'll go selecting or muting you, and then you can ask your question or a contribution. I can cite our chairman, CPAN, available in this meeting, and other great fellows. Please, it's time for questions, contributions. You indicate by a raise of hand so we could have some order. And then she will do justice to our questions. Thank you. Yes. You are asking, the slides should be available. You can have the slides. We already have the slides. So you will have the slides. All right. Please, questions, contributions on evidence-based clinical pharmacy practice. Well, while we'll await so that we could maximize our time, we have 30 minutes so as to maximize the time. While we await the compilation of questions, contributions, Dr. Joseph Madu, our dear chairman, National CPAN, I think we would like to acknowledge you and then have your contribution or award for us tonight. Dr. Joseph Madu, over to you, sir. Meanwhile, we await your questions and your contributions. Indicate by a raise of hand, please. Over to
Good
you,
evening.
Chair.
Good evening from Nigeria, everyone. Please, am I audible enough?
Yes, we can hear you, sir.
Okay, good evening and good afternoon to Dr. Tari, who said it is now afternoon in America. Good afternoon, Dr. Teresa Pounds. Yes, good afternoon, Dr. Teresa Pounds, our keynote address speaker at the last CPAN International Conference. Good afternoon to all our diaspora members. I can see Dr. Annette Nababo, their diaspora coordinator. She has been doing wonderfully well. I want to thank everyone and permit me to also thank all the participants. Like the moderator said, we have about 80 persons on the attendance list, and that is a good one. Since no one has asked any question, permit me to maybe start the questions. I want to ask Dr. Tari how we can reconcile this scenario. Sometimes when you want to give treatment, let me say to a child, to a baby that is having running stomach only several times a day, and the evidence you may find in the books or in the literature is saying that you just give probably ORS and then keep on rehydrating the child, that the running stomach or diarrhea, for instance, is usually caused by viruses, and you just keep on rehydrating the child, and sometimes the child may not be getting better. So I'm aware that in some clinical settings, they may later add treatments like ceftriaxone. I know that something like ceftriaxone or ceftazidime are not antiviruses. And then I have an experience whereby a physician told me one time that you better go and give this child something good, oh. Give metronidazole to the child. Don't just keep on rehydrating. This child will die, and they will tell you sorry in the hospital. Now, what I'm saying is that probably in the hospital policy, you may not be permitted, or they may not be permitted to use something like metronidazole or antibiotics, but rather it is claimed that the condition is most often caused by viruses. But you know, in maybe evidence, let me say evidence-based practice now, not based on literature anyway, you know that you need to add something like maybe metronidazole or some other antibiotic. Now, how do you reconcile what the literature is saying as against what you know in practice? I'm throwing the question to Dr. Tari or any other person who may want to help me in explaining this. Once again, thanks very much for giving me the opportunity to speak.
Thank you, sir, Dr. Joseph Madu. Our presenter, Dr. Tari. We have a couple of questions coming in, but I think you can start with our dear chairman, Dr. Tari, are you with us?
Yes, sir. Can you hear me?
Okay. You start with that. I'm taking down a series of questions from the chat box.
Okay. Oh, well, I know that's a really tricky situation, like trying to balance what is obtainable, like, out there scientifically and the practice that you see locally. Yeah, that has always been a challenge. I've experienced it myself too. Well, what would we say usually is that in as much as there is a best practice, the practice should be based on evidence. As long as it's evidence-based, like for the diarrhea thing, we know that, okay, yeah, hydration is there, but there are different levels, okay? You hydrate, you change the diet, the hygiene thing, zinc supplement, probiotics, sometimes metronidazole, and things like that. We know that that is also something that is being implemented. But so I think it's okay to use your best judgment, trying to align it or adapting it to your practice based on, the particular setting that you find yourself. Some of us who are in the US are familiar that this is a digression, but I'm just trying to relate it to what Dr. Mado has just asked. We know that when you have certain conditions, like it's hard for you to get antibiotic prescription. And yeah, we know that that is a policy to, curb the whole misuse of antibiotics and things like that. But there are times we know that this is more than just saying I should take Flagyl. This is, this requires the use of a more broader spectrum antibiotics. So I mean, I might be wrong, I might not be absolutely correct, and I don't feel that there is even an absolutely right or wrong answer to this, as long as it's in the confines of that evidence. Like, you're not just going to use one weird thing, like, okay, I'm using just one drop that is totally off label. As long as there is some evidence that, okay, this is applicable, even if it might not be maybe for the grade of condition you're treating, it might look like, oh, you need to start with this first, just hydration. And you know that, okay, from my experience, this is what I've seen. So you could, step it up to use the higher level of therapy, as long as it's still within the evidence that is available globally or nationally, or as the case may be. I don't know if that makes sense, but as long as it's within, we still have the option of using our best practice in alignment with available evidence. I don't know if that answered the question, Dr. Mado.
Yes, thank you very much.
Thank you.
All right, thank you, Dari. A number of questions are here from Dr. Hamidu. What's the difference between evidence-based and value-based? I don't know, you take them one after the other, or I read through them, and then you do justice to that, and they are right before, yeah. So what's the difference between evidence-based and value-based?
I think we talked about it. Okay. Do I go on? I think it will be better because I'm trying to scroll. I'm unable to scroll here.
Okay.
Okay.
Well, you can see the questions, right?
Yes. I don't know what the person means by value-based. Value in what sense? Value to the patient or value to the provider? If it's to the patient, like I think I mentioned something like that in the slide, that when you use the evidence, you still have to integrate it to make sure it matches with the value and preferences of the patient. So yeah, there is evidence, but you must still respect the patient's preference and values. So yeah, you would take the value-based care, if I'm understanding what the person is asking, over the evidence-based, because we can't force treatments on patients.
Okay, thank you. Yeah, you did mention that we integrate the evidence-based to culture, setting, values. Dr. Fan Bitrus, well, I have two pharmacists with their hands up. I'm going to give you that time. Let's just go through those that have penned down their questions. Pharmacist Bitrus or Dr. Bitrus, how does a pharmacist cope with unupdated treatment guidelines amidst physicians making use of multiple guidelines in their treatment modalities? How does a clinical pharmacist who finds himself in the midst of physicians cope with unupdated treatment guidelines amidst physicians making use of multiple guidelines in their treatment modalities?
Yeah, it's really depending on the setting. It can be really challenging, and depending on the kind of relationship also that the pharmacies have prior to bringing in their recommendation have developed. So for this particular question, I think relationship, I would say, is even more important than the knowledge that you know. The thing that you know that you're trying to sell to them. There is a common saying that people don't care how much you know until they care how much you care, or until they know how much you care. So if you're just standoffish to say, we see, commonly when I was in clinical practice, some pharmacists just communicate in a kind of way that can be offensive. Sometimes I put myself in the physician's shoes. And I'm like, if a pharmacist does that to me, I will react. Like saying, hello, doctor, please check your prescription. That's not communicating, right? So I watched scenarios where there was no acceptance of these recommendations to when I had the privilege to be in charge of a particular setting. I started to communicate effectively with them, and I would say 99% of the time the recommendations were accepted. So there was something we learned in our Special PharmD program, thanks to Dr. Pounds and her team. They taught us something that when I implemented it gave me a 360-degree turnaround in my practice style. They said, do not provide any query without a recommendation. So when you're saying check your prescription, you should say something like, oh, I see that you prescribe this. Currently, this is what is recommended. Is there a reason why you prescribe this? I was just checking to make sure. However, this is the current treatment that is now being used for this. You may want to check and make adjustments, or, if you communicate in that manner, you are showing them the problem, you are giving them the solution, and you are suggesting. It is easier for the doctor to just say, oh, okay, thank you, implemented, and they change it. It's as simple, but not simple as that. So it takes a lot of work. You need to do a lot of education of other healthcare providers. And when they begin to see your relevance, they will start listening to you. In fact, at some point, the doctors themselves will be like, come and join us for the ward rounds because we need your inputs. So if you're able to demonstrate value to that extent, I think it won't be a problem suggesting or telling them, recommending the guidelines that are current. So I think it's a more of relationship building question. Yeah, I don't know if that helps to answer.
Yeah, thank you, Ma. That's great. And I'll just like you said, it's about relationship. I think I'm privileged to work in the world, and some of the reasons why it looks as if physicians use different guidelines. I think, well, to show you that they are knowledgeable, to show you that you're one-sided, you just come and say this treatment is not, just like you said, you are opposing a treatment regimen, and you have no recommendation. So they come with different guidelines to bamboozle you. But if you have good relationship with them, I think, and you are also knowledgeable, you are good to go. There are some pharmacists are invited to join rounds, while others, well, you come around and they don't just want to have your time. So I think that's what it is. The doctors use multiple guidelines, some professionally, others to just show ego. It's up to you to relate and then prove your onions where they are. The other question is, Dr. Peter, how do we minimize antagonistic foods/nutrients drug interaction, especially in the elderly and the critically ill who are associated with polypharmacy? How do we minimize antagonistic food-drug interaction, especially in the elderly and the critically ill who are associated with polypharmacy?
Yeah,
over to you, Dr. Tari.
Yes, sir. Thank you for the question. Yeah, I think it's still just have to do with advocacy. Patient education is a continuous thing. As a pharmacist, if you are aware of certain things, like we know that, okay, grape juice should not be used in people taking like spironolactone, those kind of things, is for us to keep educating the patient and, applying tools like maybe pictorial diagrams, or having to say this over and over, even for people that may not need it. And one thing that would help to do that is to have a systematic protocol on counseling patients. Some of us, I don't know how many of us, you may or may not have it, but it's good to, on your own, maybe as your own personal practice, or if you want to even sell it to your organization, have a protocol, like when the patients come in, what do I do first? What do I say first to? Have it written out. You can even use it at the beginning. You can be peeping into like a cheat sheet to say, okay, I've talked about the dose, I've talked about drugs, I've talked about food, I've talked about other medication, I've talked about, if you have that kind of systematic guide to help in patient counseling, that would also really help. And like I said earlier, advocacy, constantly talking about it and educating the patients, the other healthcare professional, and all that. I think that would really help and go a long way.
Thank you. Thank you, Ma. We have two hands up here, Dr. Ejiro and Dr. Uchioma. Dr. Ejiro, please, you are online. Can you unmute yourself? You unmute yourself and
yes.
Ask your question, please.
Good evening, good afternoon to everyone. I want to thank the presenter, Dr. Tari, for a very fine presentation. And I also want to especially salute the National Chair, Dr. Madu, for creating this platform and sustaining it. Mine is more of comments, not statements. First, I want to refer back to Dr. Madu's question on the issue of the running to using antibiotics and all of that. Like this topic clearly stated, use of data in clinical practice. We want to first ask ourselves, what is evidence? What we refer to as evidence, which we are using for clinical decision making, is simply published strategy for managing a case or collection of cases and the outcomes. And that is what is analyzed to draw up a guideline. And in Nigeria, we seem to have a whole lot of data available that we are not making use of. By that, I mean data we need to collate, analyze, and draw up insights by way of publications, which can now be referred to for further case management. It is important that we do more in terms of documenting these practices and publishing them. Oftentimes, you also have a situation where your lab results doing something, and what you are seeing in the patient is obviously different. And some professors will tell you, we don't manage results, we manage the patient. So where you have such divergence, you manage the patient based on what you are seeing, not based on what the result is saying. So that is the essence of documenting. Now, having said that, I want to go back to data. As pharmacists, we want to delve seriously into the data space because, like Dr. Tari mentioned, the future trends, well, in the UK, it's already happening, maybe in Nigeria in the near future. The use of AI and machine learning, it's taking over all practice areas, including pharmacy. We already have AI-powered surgical equipment, diagnostic equipment, and we're also having it in pharmacy practice. Now, the simplest of the AIs we know is our ChatGPT, where you can just type in a query and loads of information is generated. However, it is that garbage in, garbage out. There are loads of applications being developed currently. It's all a question of the algorithms you put in. And the machine can pull up references from the AI can pull up references from everywhere. So it's just a function of what you put in. In the industry in the UK today, you have loads of data jobs that are taken over by other healthcare professionals. So as pharmacists, it is high time we take up this responsibility, this task of coming up with programs. Gone are the days where we just use only SPSS to do analysis. Even your simple Excel, you can do wonders with that. You have Tableaus, you have Power BI, you have loads of other applications. So when it comes to pulling up clinical data and drawing up insights from this data, pharmacists need to programs like this. We can continue to train ourselves on how to use these tools to improve clinical practice, rather than leaving it to data scientists and others saying, oh, it's not a pharmacy team. It is now a pharmacy team. Thank you very much.
Thank you, Dr. Ejiro. Thank you. Dr. Uchioma, please, can you unmute yourself and ask your question, please?
Good evening, everyone. My name is Uchioma Nwizu. Clinical pharmacist. Have been practicing I'm practicing in the US, and I'm a member of the CPAN diaspora as well. Thank you so much to the former speaker who offered to follow up on Dr. Madu's question about when evidence does not line up with our experience. I think that has helped me not to say much, because I think he has taken care of that particular issue. The evidence, a lot of the guidelines that we have are based on long-standing evidence and long-standing experience. So we can't really run off with our anecdotal experience and say, oh, metronidazole is what works now. The other thing that I want to stress is that it behooves us as pharmacists to be champions of antibiotic stewardship. And so I think part of that question was, how do you make people prescribe, stop prescribing antibiotics unnecessarily? It's very important that we take on that task. And it's one place where I think is a very green area in the Nigerian practice, where pharmacists can go and occupy and take on the task of making sure that we police the use of antibiotics. In the US, the antibiotic prescribing practice didn't happen overnight. It was years and years of education of the prescribers, and years of also seeing that the resistance pattern, the reason we do antibiotic stewardship is because we're trying to prevent resistance. If you notice, in the past, I think more than 10 years, we don't have any new antibiotic that is coming up. So we are reusing old medications and we are having increased resistance. And so it behooves us to preserve what we have, and it behooves us to begin to continue to educate. A lot of the changes that happened was because people were now seeing, number one, the resistance pattern, which we say, and then different health establishments began to modulate the way the doctors prescribe these antibiotics, and we started seeing changes in patterns. So some of the cultural changes in prescribing habits will be won by pharmacists who sit down in a particular place and begin to work on a particular issue, whether it's antibiotic stewardship. If a pharmacist develops 10, 15 years of their career on antibiotic stewardship, they will see the needle move, and somebody comes and takes in another portion of that. The needle will move. The IDSA guideline, which is the Infectious Disease Society of America's guidelines, have been long-standing, proven, and they are very beneficial, and they are available to the public, so you can always look it up. Also, make sure that people are doing cultures, and so that you can best inform them on what to do. So if a child is stooling, and you can do a culture before you do anything. You can do a culture so that you know what to prescribe, and not say this is what is going on. We can use ceftriaxone, because when you lose ceftriaxone as an antibiotic, you don't have another third-generation cephalosporin that you can use for other disease conditions. So it's important that we occupy that space. The second question that I want to respond to is a question about people using multiple guidelines. Just because I also want to throw some light on the use of multiple guidelines, I sometimes use multiple guidelines, and I do that when different patient scenarios make me choose one guidelines over another. For instance, in the management of diabetes, I could use the American Diabetes Association guideline for a particular patient, and for the next patient, because of peculiar circumstances, the endocrinology guideline is, American Association of Endocrinologists guideline provides my answer, and I use that. It doesn't mean that I don't know what I'm doing. It just means that this particular guideline answers the question for this particular question, or helps me for this particular question, but not this other patient. One thing I want to encourage us as pharmacists, as we begin to discover these guidelines, is to know the reason behind guideline recommendations. So if a guideline says use metformin, why did they say use metformin and not say use maybe glimepiride or another medicine? What helps us as knowledgeable pharmacists, apart from what the speaker said about building relationships and making sure you have a cordial, respectful relationship with your doctor colleagues, but also knowing a little bit beyond what the guideline says and knowing why the guideline says it. When you do know that, then you can intelligently speak to the doctor and have that conversation. You have gone a step further. And sometimes when the guidelines will say do this, they always annotate it so that you know which research article they used to build that their guideline statement. You go and read that research article, and then you can come up with a healthy knowledge of why we're doing what we're doing. That way, your conversation, you bring real value to the conversation, because everyone can go in and read the guideline, but not many people know the information or the reason behind the guideline. Thank you so much.
All right, thank you, Dr. Chema from the US. Thank you very much for that contribution. Dr. Tari, I have a question, a contribution, because I'm not seeing any hand raised here. It's a question, it's a contribution. Evidence-based vis-a-vis reality, just like Dr. Madu said, in this part of the world, in Africa, Nigeria to be specific, I practice in Benue State. We know, it's a fact, that most of our drugs are a little compromised. We have different generics that we use, and as pharmacists, we are custodian of drugs. In practice, I've seen drugs fail patients. It could be anti-malarials, antibiotics, name them, maybe due to bad excipient or low active ingredient, not meeting standards, unlike in other climes like the US or UK. Now, a guideline is developed. Let's say those, and most of the guidelines we used are not really our own guidelines. That's a fact. A few local places must have done some job to develop their guidelines. So just like Dr. Tari said, your evidence base should suit the community or the setting. So with what we have, compromised drug markets, compromised drug quality, different generics, now you have guidelines telling you that you use also medication. For instance, amlodipine for a hypertensive patient, 10 milligrams, OD daily for 7 days, 14 days. Assuming the half-life is maybe within 24 hours or between 20 to. So you working without guideline, you are working without guideline, you have researched, you have checked, but here you are administering a medication that just before you get that half-life is not the exact half-life because the drug is compromised in our setting here. It's not, I'm not speculating, I know what I'm saying for a fact. Gefriazone, you are giving and the drug is compromised. Now you following the guideline, following the frequency, following the dosage. So as I practice in the world, like I said, if a physician gets confused as to why this drug is not working, it's not delivering, he's followed the guideline, or a clinical pharmacist has followed this guideline. And because the drug is compromised, we have different kinds of drug market in that scenario, and the patient is here. So how do we handle such a scenario? Is the public, or I don't know. I just want some clarity over that, because you could lose patient following a guideline. A drug that its half-life is supposed to be 3 hours, or let's say 6 hours, you are dosing it 8 hourly, 6 hourly, and it's really not so. And you see a physician opting it up, maybe because he feels. I give an example. We're having a round just a week ago. I work in the psychiatric unit of my hospital, and a question was asked. Olanzapine is to be administered 10 milligrams daily, half-life between 20 to 24 hours. Yes, 20 to 24 hours. So, but here is the patient not responding, and another doctor, based on empirical, whatever, not really guideline stuff, he put the patient on olanzapine 20 milligrams. And the question is thrown, what's the clinical benefit giving 20 milligrams and giving 10 milligrams? And the doctor had to say, well, this is our experience. you give 10 milligram olanzapine and what you actually have. So when do you achieve steady state to control this psychosis or psychiatric condition? Because what you have is not what it is. So, Dr. Tari, following guidelines, and you're a physician, you're a clinical pharmacist, and you are confronted with a drug that's really not meeting standard, what do you do? And the other one is like a contribution based on the question I've asked. I think in our climate in Africa, Nigeria, we still also need to get data. The job is on us as clinical pharmacists. That's my firm belief, to get data that is peculiar to our environment, our community, and also develop our own guidelines. Just like you said, evidence-based, depending on the scope of the research, that authenticates it or validates it. So, but I feel that if we are using evidence-based that is on the global scale or national scale, we should narrow down also, get data, make research, develop our guidelines for our own community based on the question I'm asking and I've asked. So please, over to you, Dr. Tari.
I think you already did justice. You're talking about the global versus local guidelines, right? Yeah. So what it says is there is this is it a body or something? I don't remember the name quite well. It says you move from global to local as much as possible. So, for instance, let me use antibiotics, for instance, just like what was it Dr. Ucheoma also said. If you have antibiotics guidelines, like let's say a national guidelines in Nigeria, for instance, what hospitals are meant to do, individual institutions are meant to look at the patterns of like antibiotic resistance, susceptibility, usage. They are meant to, based on their own local environment, generate what works for that community. And that is the guideline they are supposed to use. So as much as possible, local over national. But most of these hospitals, some of them are developing these guidelines actually, and they use them locally. But where the local guidelines are not available, you move to the next available one. That's what I think.
All right, thank you. So concerning our drugs, substandard drugs, different generics. So what do we do?
Well, I mean, from most of us have these experiences, right? Both in hospital and community settings. Sometimes because I personally have had several first-hand experiences. I remember once I had a patient that had an edema, and furosemide was prescribed. And because they went, maybe because to avoid costs, they went outside of the hospital to purchase a very funny looking brand of furosemide. And when I went to check on the patients to do reviews and all that, I saw that the edema wasn't resolving. The wife actually complained. And I decided to give them the Lazis brand that we had in the hospital. And I told the nurses I'm taking that one away and they should use that one. And by the next Monday, that was a Friday, the edema has resolved. The patient was better and he was discharged earlier than expected. So in as much as we want to do cost effectiveness, we should also remember the cost of ineffective treatments. So if we know brands that can be trusted, then we should go for those brands. Unfortunately, they are more expensive, but the cost might be more if we keep trying and trying.
Thank you, Dr. Tari. And it is the last question here. Let me see, who is that person? Dr. Pharmacist Sylvia, please enlighten me on the incorporation of clinical pharmacy practice in community practice. Asking to be enlightened on incorporation of clinical pharmacy practice in community practice. How do you bring to bear clinical pharmacy practice in community practice?
I think I responded on the chat, but just to re-emphasize, community pharmacy practice is still clinical practice in the community setting. So it's the same activities, but different settings. For instance, you don't have the hierarchy of or other healthcare professional making the decision in the same setting, but we deal with doctor's prescription, right, in the clinical setting. But we don't have the chance to like go back and ask questions like we collaborate in the hospital. I don't know if that's what she meant, but sometimes you can go as far as calling the physicians. I remember when I used to be in community practice, with time we developed a physician list contact, and we tend to reach some of them when it is necessary to just establish that, oh, this patient is here, we want to do this adjustment, is it okay by you, and all that. But I believe you can always implement clinical pharmacy practice in community. It's already a clinical setting.
Yeah, that's true. Thank you, Ma. I could see the hand of our national chairman, I think, for the second time. Before him, and I think Dr. Ejiro, I don't know whether for the second time. Dr. Anit Nabo from the US, they said, Dr. Anit, please, can you unmute yourself and ask your question? We'll get back to our chairman, who will also be doing the closing remark. And we'll have Dr. King Charles immediately after Dr. Anit. Please, Dr. Anit, can you unmute yourself, and then followed by Dr. King Charles.
Thank you very much. It's not so much as a question. Since you had said you didn't have any more questions, I thought I would do a quick remark and, first of all, just say big thank you to Dr. Tari. When I approached her to help us represent CPAN Diaspora, she was very gracious, and she's been very active as a member of the Diaspora group. So thank you very much. I just wanted to do a quick remark on the many questions that come up and many suggestions and answers. I think this conversation has carried us in so many different directions that was not originally intended, which is really great because it brought out a lot of things that a lot of people might have been thinking about. Just thinking about evidence-based practice, that should not substitute the different tools that you would need for diagnosis, for proper diagnosis. Again, just trying to touch base on that pediatric question, that while you may think that every time there's diarrhea for a kid, usually in general practice, giving metronidazole has resolved many of the cases, but that should not be preferred over proper diagnosis of what you need to do. And a lot of times for pediatric patients, there is a more conservative prescribing for them, just for the mere purpose of their signs and symptoms are often not clearly explained by the pediatric patients themselves. So that will behold you to do a better investigation to figure out what is truly wrong with that patient before you embark on treatment. Hence, giving fluids or stuff like that is always the first recommendation and like the holding ground for most of them. I also think that it's also exposed problems in our lovely country for counterfeit products. Again, evidence-based can help with that, but that kind of brought that out too. And knowing that that is something that is very predominant in the country, hopefully with time, it's predominant everywhere. It's something that every country is trying to fight. And I think even the US doing stuff like the DSCSA, and I can maybe talk about that on another platform, is really helping to limit and restrict the distribution of medication in the country. In other words, if you enter any pharmacy, how that program works, if you walk into any pharmacy or any establishment that has medication and pull any medication from the shelf, once that program is fully implemented, you should be able to show not only paper trail, but even digital trail from when that medication was manufactured to all the different distribution channels that it has passed. So that's some of the programs that US is using, and I know Nigeria is not there yet, but that's hopefully we have people in our platform that kind of work in those areas that will start to help implement. That's the purpose of all of this. We all come together, we exchange ideas, and we go to our different settings and try to start doing things a little bit differently. And one step at a time, we'll be able to make changes, positive changes, just like pharmacists probably making suggestions to providers, the different communication styles that you need to use. I mean, prescribers or providers are not necessarily more educated than us or know-it-all people. I think the problem is the communication style, how you approach them. And like Dr. Trauma said, doing your own research as well, ensuring that you know what you're saying and know all the other possible resources that provider is coming from. You may have just read one resource and come up with your suggestion and say the new guideline is saying we should do this. However, that provider may also have orders that they have reviewed. So coming at them with the idea of collaboration versus I am here to correct you, right? So even as a pharmacist, if someone tried to correct you, there might be some resistance. So we should always remember that as we deal with other colleagues or members of our healthcare profession. I could talk on and on and on, but because of time, I'm going to go ahead and shut up. I really appreciate you all. I appreciate the audience, and I thank you all so much for this platform. Thank you, Dr. Tari.
Thank you, Dr. Anit. Thank you for that contribution. Dr. King Charles, please can you unmute yourself? Is Dr. King Charles there? Can you unmute yourself?
All right, yes, I'm here already.
Okay.
Thank you for the opportunity. And I really want to thank the presenter for a job well done. Then the question I want to ask is this, is concerning when you are at the middle of making decision between value-based and then evidence-based. All right, let me put it this way. For instance, the prescriber, when you are the one in charge of dispensing a particular medication, I don't know if I'm audible enough, sir.
We can hear you.
Okay, now, but you know that value-based, that the prescription won't actually help the patient. There's no clinical benefits that the patient will get from that drug. In fact, not just that the patient will not benefit, but it might also cause harm. And you've also used the best of approach based on communication to try to negotiate and make the prescriber see things that way. Okay, then based on that, what are you supposed to do as a pharmacist? Probably the drug's supposed to move from you. The prescriber has already ordered for it, but you are the one to let it go. But you know that there are issues and you've tried resolving it, amicably using the best of approach. So what should your decision be on that? Thank you, sir.
All right, thank you. Dr. Tari, do you understand him? Yes, you understand what he's saying?
I think I do. There's what they call, of course, the patients are not the ones making the decision, right? It's the clinicians, of which we are part of it, that is making the decision. So if a patient is bluntly refusing, then there's what they call signing against medical advice. So
no, not for the patient, not for the patient. He is saying you've done your collaboration with the physician or the clinician as a pharmacist, and you got some query on the prescription, and then you are the last link to the patient to give the drugs, but you know too well that the patient will not benefit from this medication. You have collaborated, you have intervened, you have recommended, and the clinician is not adhering. Do you go ahead and dispense the drugs to your patient? That's what he's saying.
I think when we experience those kind of scenarios where doctors insist, we experienced it, I'm sure most of us, you document it, like do your documentation, write your notes. This was the recommendation, however, this you would dispense as the prescriber has said, but you make sure that documentation is there just to protect you legally. I don't know if someone else has something else to say.
Well, I buy into what you have just said. That is the right approach. We are not in a war zone. Meanwhile, he should take responsibility. If you pharmacists know what you are doing, if I know what I'm doing, and he has said that, so I document, I have my evidence, I have my records. So whatever comes out of it, he should take responsibility. In my facility, what we do, you have to countersign, and at that point, on the prescription sheet, I'm supposed to sign that I've dispensed to this patient, but if I notice that this is not supposed to be, I give the prescription to the prescriber who countersigns that yes, I've raised an observation. He insists that this is what should be, so he countersigns. And in most cases, if they are not sure of themselves, they will not countersign. And then that way we sit down and see what we'll do. But a physician that is sure of himself will countersign. And all these are evidences that will protect you and then put all the responsibility on the physician. That's what we do in our facility. Thank you. Dr. Joseph Madu, our dear chairman, your hands are up, and Dr. Ejiro, I don't know who comes first, but we'll give you this the floor because our time is running out.
I want to confess so that the national chairman can wrap up.
Let Dr. Ejiro speak, please.
It's all right.
Thank you very much, National Chair.
Okay.
I want to.
Dr. Ejiro, yeah.
I want to disagree with the moderator, pharmacist Matthias, on your statement with regards to the generic drugs not meeting standards in Nigeria. That is not entirely correct. There are loads and loads of generic products that are good in Nigeria. The question is, where and how do you get your medication as pharmacists? That's the big question. A lot of us go to the open drug markets, and I understand some institutions, the drug revolving fund, have been taken over by our physician colleagues. Now, when that happens, as a pharmacist, where you are having issues with failures, the next action for you to take is to do analysis of those medications. Ideally, when any supply is done, you're supposed to do random analysis. You take random samples and analyze. That is where the quality control labs come in. Institutions that don't have, like my institution, Delta State University Teaching Hospital, we didn't have, I don't know if they have now, I've been out of there for about a year. Now, when we had a scenario like that, we took it to FMC Asaba because they had a quality control lab. Institutions that don't have, they can go to the nearest faculty of pharmacy, the Department of Pharmaceutical Chemistry. They will easily just do that analysis for you. And when you do that, you're able to tell if that product meets the necessary requirement. If it doesn't, the supplier is bound duty bound to come and replace it. So those are the ways you ensure the integrity of your product. However, your product can still be meet requirements. You still can have treatment failure because tissue response vary. Now remember, it also snowballs into the case of getting to go more than the recommended dose. Remember, the dosage recommendation for each of these medications is not for the entire population. It's for majority of the population, the dose that will give the desired therapeutic outcome for majority of the population without giving, without toxic effects. So you could still have outliers. I'm saying this because we once had a patient, a diabetic patient, whom we had to double the maximum dose for that patient, for the patient to have response. And the patient had been on that for years. In fact, it was the team that came from the UK then. We worked with that team. Apparently, this patient had been like this from the UK before the patient came, and we were sticking to this is the recommended maximum dose. And until we doubled, without monitoring the patient for adverse or toxic effects, none. And the patient responded to that. And that was how the patient went home. So these things are not cast in stone. As pharmacists, we need to continue to work with the rest of the medical team while updating our knowledge base to be sure that we are getting the desired therapeutic outcomes. Thank you.
Thank you, Pharmacist Dr. Ejiro. Thank you so much. I agree with your points and explanation. However, you know, we are in the, what you said, out of several institutions in Nigeria, how many have side labs? You didn't have, you have to go somewhere. So that's resource limited settings, and that's one, to prove the integrity of our drugs. We don't have, people just supply from Onitsha, from anywhere, and then we just get them and patients just consume them. I agree with your recommendation, but how feasible, how realistic it is in our setting, of course, it could be several factors. But out of the institutions in this country, I can beat my hand on the chest and said, you won't get. And then number two, outside of the quality and integrity of our source, do we have to do what is called therapeutic drug monitoring? Maybe just a few centers. So we truly are limited. So I agree with what you're saying, that there are some generics that meet up to standard. But again, it's a fact that there are a lot of other generics that didn't meet that are not meeting up to standard. And you talk about tissue response, fine. That's why we said therapeutic drug monitoring, but we are in a resource limited setting, or maybe for lack of goodwill or political will or corruption or something. So we have a long way to go. I agree with all that you have said. There may be good generics out there, but how do you confirm it? How do you confirm that it's good to go? And how do you monitor it in tissues, in patients? So I agree with your point, but again, you agree with me that we don't have those facilities. We don't have the political will. We have a long, long way to go. So just like Dr. Tari said, I think I go with her. You go with generics that you know, even the generics that you know that will deliver. Some can also be faked, but I think it is only safe. The process of trying to do a side lab, test this, and come and do therapeutic drug monitoring, we don't have those luxuries. So you go for a brand you know. For instance, say Ceftriaxone, what is the bumper Ceftriaxone now? Rocephin. For my children and several other people, pediatrics, you just go for Rocephin. You know, except as a pharmacist, of course, I know other brands like Oxazone. There are brands that deliver too. But in a situation where a doctor or a pharmacist, a clinician is gambling, just go for what you know, like Dr. Tari said, to save the life of the patient. Because the quality of our generics, except tested, you cannot guarantee it. Thank you, sir. Dr. Joseph Madu, our dear chairman. There is someone who wants to ask a question, but I think, do we close the curtain here? or we allow the person ask a question before you, sir?
Can I say something real quick when it's
Okay,
has to do
okay,
with
okay.
authorized generics? So there's
Okay.
what they call the authorized generics. I remember having to do a training for Sanofi sometime in 2020, and that was the concept they were trying to push out. So these are like generics from the same company, but they don't carry like the brand name. So that makes them more affordable, but everything from the production and all that is the same. So that helps in, curbing some of the problems we have with fake substandard medication. So adopting an authorized generic practice style can be a way forward. I just thought to mention.
That's great. Thank you, ma. So if we have authorized generics, I hope people will not bribe their way to have the generics authorized. So, well, it's a good part to go. Dr. Joseph Madu, our dear chairman, please, sir, over to you.
All right. Good evening once more. Please, am I still audible enough?
You are very, very audible, sir.
Okay, thank you very much. Thank you, everyone. I can see that the night is fast spent, at least here in Nigeria. It's already 11 p.m., so it's late, and I know we need to go now. But let me thank the diaspora pharmacists, the PAN members. Please, along the line, something came up, but I've just been thinking of something. And that is, people kept talking about guidelines, and guidelines. When we established CPAN, not up to a year from establishment of CPAN, how do I put it now? We inaugurated a pool of experts. The CPAN Apex pool of experts gave rise to the specialty groups we have today. The CPAN Apex pool of experts is a kind of, is it an ideology borrowed from UK Clinical Pharmacy Association? And I'm aware that both UK Clinical Pharmacy Association and the American College of Clinical Pharmacy sometimes even have guidelines. Sometimes they develop guidelines, they make definitions and this and that. Now, what I'm trying to say, please, is I'm throwing it to the diaspora coordinator and our members, Dr. Aniel. Somehow, the CPAN Apex pool of experts, I don't know what grammar calls it. Is it moribund? It has gone into, it's no longer really active and functioning. And I think we have said that in one of our meetings, that we need to change the leadership of the CPAN Apex pool of experts. If it works somewhere else, it should work in Nigeria. And I want the diaspora, I want to give it to them as a challenge. Since we have been saying that we need to develop our own guidelines, those of you in the diaspora should please help. Get for us in Nigeria, we are not saying you do everything. We can also get you new people. We don't mind if the CPAN pool of experts will be headed by someone from the diaspora CPAN. But we want to work together. We give us someone to head it that maybe we will sacrifice some time for CPAN. And because as I'm saying, under the terms of reference, we had a subcommittee in the pool of experts that is to assist in developing guidelines in Nigeria. We have the hospitals, we have our members in the hospitals, we have some physicians we are collaborating, we have other people. I don't know, even if what we have to do is skeletal sometimes, but at least we should start doing something, working towards guidelines. We currently also have the Pan-National Research Committee. I'm yet to carry my hammer to that place and ask them what is happening, though we inaugurated it close to the conference. but we have not had much again from them. They have a chairman and co-chairman. But please, what I'm trying to say in essence is that I will like the band diaspora to give us maybe someone, or either as an assistant or a co-chair for CPAN APEC School of Experts. And one thing I want us to address is looking at guidelines development for Nigeria. I don't know if I'm well understood, but thank you very much.
Thank you so much, sir. Thank you. And I want to thank our dear Dr. Tari and everyone who participated in this presentation. I don't know, our dear chairman, sir, I hope all that captures your vote of thanks. So can we close the curtain at this junction, Dr. Tari, in the absence of any other contribution? The time is fast spent here in Nigeria.
Sorry, I don't know, is it possible for the coordinator? Is it possible for diaspora coordinator to say just a word?
Okay. Thank you. So the coordinator, Dr. Annie, please, I think you have to say a word. And
Thank you very much. I'm thinking you're probably saying in response to your comment, because I did take a minute earlier to thank Dr. Tari and everybody that participated today. Dr. Madu, your request is well noted and will be communicated with the diaspora team in terms of making sure that expectations are within reason for us at the moment. I think maybe starting with reviewing current existing guidelines may be a good place to start, because there's a whole lot more involved in creating your own guidelines. There's a whole lot that goes into that that I don't think myself or probably most people collectively put together that we are at the point to be able to generate some for right now. So, but maybe reviewing current existing guidelines and best practices, if that will suffice for now, maybe a good place to start as we continue to explore what it would take to generate our own guidelines, all the research that is involved and stuff like that. But is that okay, Chairman?
That's perfect. That's perfect, please. Perfect. Thank you.
Thank you. Thank you very much. Thank you all so much. God bless you all. I will defer now to our chairman for his closing.
Thank you very much. Okay. All right. Thank you, Dr. Anit. Dr. Joseph Madu, are we safe to draw the curtain here with a closing prayer?
Yes, please do.
Please, every other question, you channel, I saw some questions on the text, the chat. Dr. Tari will respond to them. And then I think some persons are demanding for the slides. They will be available. And I hope this is on record. Dr. Bello is there. So we'll have all the materials to be sent on the platform. And if you have individual requests, thank you very much, and God bless Ejiro. So close us with a word of prayer tonight until next edition again. Thank you. Is Dr. Ejiro there? In the absence of the Dr. Ejiro, are you there?
I can close you from the diaspora. This is Dr. Tamedi. So let us pray.
All right. Okay.
Father, we thank you for such an awesome meeting. We thank you for the wisdom that you've given our presenter to share our experience with us. Father, we thank you for the opportunity that you've given us to be able to impact our colleagues, impact our population. And we ask you, even for the ask that they've asked us, that Father, you give us access, open the way for us, that the things that we're needing to provide for them to help them even move on to the next level, Father, you will give us. We ask everybody that is here today as they go to work tomorrow that, Father, you bless them. Even this weekend, you keep us all safe. And we thank you. And the next time we meet again, in the name of our Lord Jesus Christ, I prayed. Thank you all. Have a great evening. Bye-bye.
Amen.
Good
Thank you.
night.
Bye. And good night
Thank
to
you so
everyone.
much, Dr.
God bless
Melly.
you.
Good night.
Bless
Thank
you.
you.
Thank you,
Good
moderator.
night.
You were amazing. Thank you so much.
Thank you, Dr.
Thank you.
Ame.
Thank you, my dear Tari.
Dr.
Bless you.
Mete. Thank you. Bye.